joint mobilizations and so forth. We talked about this before. Manual therapy techniques that are used to modulate pain and treat joint impairments and limit range of motion by specifically addressing altered mechanics of the joint. So, skilled passive movement of a joint is the best definition I have heard of manipulation, and it kind of covers the mobilization as well. These terms can be used interchangeably. Back when I was in school, it was like PTs did mobilization and chiros did manipulation. Now, everybody does everything now. It's just what it is. Manipulation historically has been more high velocity, but again, skilled passive movements of the joint is the best definition that I've heard. Documentation can be a little bit difficult because you've got to document the position, what you did. Got to make it reproducible. So you got to get the patient position, you got to get your hand position, you got to address a lot of different things there. So some quick definitions. Again, mobilization or manipulation can be small amplitude and high velocity, large amplitude and low velocity, or somewhere in between. And we'll talk about this all semester with different joints. Self-mobilization, self-stretch techniques, using joint traction or glides. Mobilization with movement, you'll see that abbreviation is MWM. This is popularized by a guy named Brian Mulligan, who made these types of deals where he would put you in a certain position, and then he would ask the patient to move, to put different stresses, appropriate stresses to this physiological movement at end ranges. Very effective treatment technique. I have never studied under Brian Mulligan, but I've been to enough, I've worked with enough people that have, that I feel like I know those techniques pretty well. You'll see a lot of times when you go for a continuing ed course, if someone pays for you to go to a 2-day course or whatever, many times your employer is going to say, for us to pay for you to go to this course, you've got to come back and do what they call an in-service. So you got to demonstrate to everybody else what you learned. And I've sat through about 1.5 million of those, so I feel pretty good about Mulligan techniques. I'll show you certain ones with certain joints when we get to those body parts. And obviously the physiological movements patients can do voluntarily. We all know those. Not a big thing there. Accessory movements. These are joint play movements, arthrokinematics. Movements within the joint cannot be performed by the patient. Component motions, so like if we want to increase external rotation of the shoulder, glenohumeral joint, what accessory movement or joint play movement or glide will help to do that? Increase external rotation. Think about what's happening at the ball and socket. Is it going to be an inferior glide, a superior glide, a posterior glide, or an anterior glide? Anterior. Anterior glide is what's occurring when we've got that roll, spin, and slide of the glenohumeral joint. So if we take a joint that's not moving very well and we apply that anterior glide to it, theoretically, it should allow for more external rotation to occur. That's what this is trying to do. So when we get to these respective joints, we're going to try to highlight that. If we do a posterior glide to, I mean, you think about it, ball and socket, right, for hip and shoulder. So anterior glide is going to help with external rotation. Same thing with the hip, anterior glide. If we apply a posterior glide to the hip, that should help theoretically with our internal rotation. Okay? If we apply an inferior force, inferior glide, that should help us to elevate the shoulder. Okay? Manipulation under anesthesia. I've told you this story, right? Knock a patient out. They've got frozen shoulder. They used to do this all the time. Go into the OR and someone with no external rotation, they would just take it. And the noises that makes, oh my gosh, horrible. Breaks adhesions around a joint, it breaks a lot of stuff around a joint. They don't do this nearly as much as they used to. They will do things arthroscopically and try to debride, to systematically try to release these adhesions. But there's still some of this, so you may see that from time to time.
Like total knees and stuff.
Yep, yep. Put them to sleep and blam. And you know what's the best part about this? Guess where they are an hour after that? With you. I've had people throwing up from anesthesia as I'm trying to range their shoulder. It's lovely. This is so much fun. And they will send them, the doctors get so paranoid about it, is after they do the manipulation, they will make them come to therapy daily. So you get to spend an hour with them every day. So much fun. They love you too. Absolutely. Muscle energy techniques, I know we've talked a little bit about using an active contraction that attached near the joint line to the line of pull can cause the desired accessory motion. We will practice this, okay? A real quick one that you can do yourself. Make a fist, put it between your knees. Squeeze tightly. Do you not, you bony people.
No, I'm sorry.
Do you feel any pull in the back here with that? You may or may not, okay? That's a muscle energy technique. You're using your adductors to pull and will effectively gap the SI joint slightly. Guess what? We all know what roll, slide, spin, all these are. Convex, concave. Look, I even left the blanks for you. If the bone is moving, it's convex. So if this one's moving, this is going down, this is going up. It's going to be the opposite. Okay. Conversely, if it's this way, both going down. All right. We just got to know which one's which. So a couple examples. This is what I just showed you there. You got the slide with the radial head here. It's a little bit of a unique situation. Angular stretching versus joint glide stretching. The lever magnifies the force at the joint and can create some joint compression. This is not usually a favorable thing. Usually causes increased pain or what have you. Joint glide, safer and more effective. It's controlled. It replicates those normal joint mechanics. Again, just think about the external rotation with the anterior part of the glide there. Sometimes angular stretching can just be difficult because of if someone has a painful joint, they're not going to tolerate this. And if you provide more compression to that joint, that's not going to be a favorable thing. So, compression, obviously that's pretty easy. Decrease in joint space between bony partners. A longitudinal pull or traction would be A here, okay? You're just taking this and pulling it downward. long axis of the bone. We could certainly do this with the humerus, we could do it with the femur, you can do it with the tibia. But if you're looking at distraction, separation of the joint surfaces, that would mean that the ball would need to come more laterally and inferiorly than just inferior. You see the difference there between traction and distraction? Because I even do this, use these terms interchangeably at times, and that's really not correct. But we can certainly position the humerus in a way that we can pull it more laterally and inferiorly. That's not good. That's a shoulder. It is out. So indications, obviously, you've got pain, muscle guarding, spasm, all these types of things we've already talked about. Reversing hypomobility, so we need to stretch somebody, we need to get them moving. Positional faults or subluxations, that would be here. That's actually a dislocation.
Is that not painful?
Horribly painful. Unless it's somebody who's done it so many times that they're just chronic dislocators. I think I told you all about the girl in our class who was a cheerleader. She could just pop anything, almost any joint in her body out. And somebody went to stand on her shoulder and it just went, that didn't work very well. Yeah, that's a dislocation. And that is 99 times out of 100 is very, very, very painful. And usually, and how do they put that back in?
Deep breath.
It's just the opposite. They will put a foot in the axilla and pull, and it will go back in. Now, a lot of times, if it doesn't work, they've got to put somebody in under anesthesia because it's so painful. I was at a ball field, kid dove, dislocated, and they always are walking off the field like this. And if you see that sulcus sign, that's a classic one there. If you see that sulcus sign, it's not going to go back in most times really easily if it's that severe. So that's somebody, they took him straight to the hospital, and I knew the kid, so I went with him. They gave him some drugs, and then they popped it right back in place.
So like in this situation, like if they have like labor issues,
yes,
it keeps. If they can't get it back, will they go ahead and just fix it?
They'll put it back in place first, and probably put him in an immobilizer or something like that for a little while. That's what they did with this kid.
Mm-hmm.
Put him in an immobilizer, and he had surgery, I think a couple weeks later, after everything had calmed down a little bit. Yeah. Limitations, we can't change a disease process. If someone is getting stiffer, we can do all the passive stuff that we want, but we can't change what's going on from a physiological standpoint there. Hopefully we can prevent some of the cascading effects of that. Can't change the inflammatory process as well. And this is huge. The skill of the therapist affects the outcome. So if we got somebody that knows what they're doing with this, great. If we don't touch them. Okay? If you're not comfortable with that, defer. Don't just jump in and say, okay, I'm gonna practice on this person. Contraindications of joint mobilization, hypermobility, we said. We can't keep stretching out those that don't need to be stretched or mobilized. Okay? If there's joint effusion, if there's fluid already there, can't do anything with that. And inflammation, again, I put that in the kind of the precaution more than the contraindication, but we'll go with what the book says here. And you can do a general oscillation distraction to help with pain, but again, we can't change the effects of that inflammation. Conditions, special conditions, malignancy. Kind of like we were talking about with things like applying heat. Just be careful with that. Probably not something you want to do. Bone disease detectable on a radiograph. I'm not doing anything with these people. Unhealed fracture, certainly not going to mobilize that. Again, hypermobility in associated joints. If it's somebody that's generally loose, I'm just not going to mobilize them. If it's one certain joint that they tend to be loose, I might do the one that's proximal or distal. Total joint replacements are designed to be inherently stable, so that's not something we're going to, try to replicate glides on. There's always exceptions to that too. So like a patella, a lot of times if you just start doing some glides on the patella, things loosen up a little bit. Newly formed or weakened connective tissue. This is delicate stuff here. You can't be real aggressive with that. And again, elderly individuals, again, I've done mobilizations on 85-year-old people, but I want to make sure that they don't have osteoporosis, that they do have good tissue, all these types of things. So you just got to think about the yellow light with those. Applying passive techniques. Look at the quality of the pain before, during, and after. How are we going to determine the pain during a mobilization? Ask them. Keep that line of communication open. Be able to see their face, okay? A lot of these people are scared and they're not gonna wanna say anything. If you see their eyes about to pop out of their head, you need to ask what's going on, okay? Capsular restriction, you guys have all felt that, what that feels like, okay? When you get to someone that first frozen shoulder that you have, and you hit that brick wall, and it's just not going any further, you will never forget it. Fortunately, we don't have any of those in here, or unfortunately, whichever way you want to look at it. But that capsular pattern and that super firm infield is going to necessitate that we do something there. You need to be able to mobilize that joint. If you see that subluxation or that dislocation like we saw up here, we can't, that's not going to be in your practice act to put that back in place, nor mine. Let's leave that up to athletic trainers on the field or physicians in the OR, ER. Again, documentation can be tricky. Make sure you're using standardized terminology in terms of positioning, your application of your force, your grades, which we'll talk about here in a minute. All that's important. So here's the grades. Grade 1, this is in the available joint play. Okay, so grade 1 is just a beginning little oscillation. Nothing really going on there. Grade 2, your motion is going to be in an oscillation in the middle of the available joint play. In terms of sustain, you can take it to the resistance and back, okay? Grade 3, this is when we start to make changes in the tissue, okay? When we get to that plastic phase, as we talked about, we're gonna apply a force that exceeds that tissue resistance, okay? It's going to stretch. And then grade 4 is going to be an oscillation that is at end range. Okay, so this one goes from mid-range to end range, this one stays at end range, okay? But again, you see over here is the anatomical limit. We can't go beyond that, or what's gonna happen?
Tissue damage.
We got tissue damage, we got a dislocation, okay? Subluxation, what have you. Does this help to see this picture? I always did for me. Gives you an idea of what the parameters of what we're talking about there. So grade 1, again, just loosening up. Very small amplitude distraction. For pain relief, 7 to 10 seconds with a few seconds in release, several cycles. Again, this is mostly just for pain relief. Grade 2. Good for pain relief. Assess the joint and then maintain, because again, you're not getting out to this plastic range. You're only here in the mid-range. Grade 3, this is where we start to make some changes here. We see stretch, we increase joint play. You can do 6 seconds. Again, this is just an example. Partial release, then with slow intermittent stretches at 3 to 4 second intervals. So I would take that, hold it, bring it back, and again, it's going to bring it back to half of the available joint play to the in range and a little bit beyond. That's going to be the grade 3. High velocity thrust, or HVT. These are small amplitude, high velocity, performed only once. Indications to snap adhesions or reposition joint surfaces. PTAs do not, this is a grade 5 here, okay? PTAs do not do grade 5 mobilization. Or at least mean to. Sometimes it might happen. You might be doing something, all of a sudden it pops back into place. Hopefully the patient says, oh, that feels great. But yeah, you're gonna encounter some adhesions at times. If you're working on a frozen shoulder and you're doing a MOB and something pops and the patient eyes get all big, don't flip out. It's probably a good thing, okay? Just keep moving, keep moving. So my story, when I was very first year out of practice, had this guy, he weighed about 350 pounds. I have told you all this one. He's got a frozen shoulder, comes in the first visit, has just horrible frozen shoulder. I had beaten him up on these glides and stuff. And he never comes back. Never comes back. I gave him a home program, I think I gave him a pulley, told him to do all this stuff, never comes back. So we have a snow day. This is up in Virginia. Have a snow day and we're calling people that haven't come back, trying to figure out what's going on. And call this guy and he goes, oh, you won't believe what happened. He says, I slipped in the shower and I've got a handrail and I grabbed the handrail and then my whole body went down and my arm stayed up. So it just ripped everything. So he had his own clothes manipulation in the shower, if you will. He says, but you know what I did? He goes, I remember you telling me to keep moving it. He goes, I used a pulley, I got full use of my arm now. So that told me right then and there that if you tear this stuff up, it doesn't always mean a bad thing. You keep moving your joint, especially something like that. Again, we've got to make sure we are documenting the position and the stabilization, the treatment plane, the progression of treatment, patient's response, that's gonna be huge. And then what are we telling them to do outside of therapy? Is there a home program? Are we teaching them how to self-mobilize, stretch it, move it, pulleys, whatever it is. Not standalone. Gotta follow up with that. Again, we'll hit every single one of these. We'll do a lot of those. We will do lab, and that is that for me talking. Goodness.
Yeah.
All right, so it is 11:30. Let's meet back at 12:45. Yes, sir.
So when you're documenting for the grades, would you document like grade 1, 2, 3?
Yep.
Like that?
Yep.
Okay.
That's exactly what you need to do. Yep. Well, hello.